actually. She's going to talk on which tonometer to use for which patient. Go ahead, Dr.
Well, thanks, Dr. Nangya and the chairpersons. I'm going to talk about which tonometer to use for which patient. It's a age-old topic, but let's just revise. These are the common methods that we use for intraocular pressure measurements, and all of us are very familiar with these in the clinics. The principles of measurement are largely flattening, indentation, or deformation of the cornea. So largely we are dependent on the cornea for measurement of intraocular pressure. These are the various tonometers that we will just touch upon. Well, IOP is a variable parameter, and most importantly, also we need to understand that it's not only the measurement, the IOP itself gets affected due to various factors like diurnal variation, exercise, systemic disease, our heart rate, etc. And further, to complicate the matters, there are factors which affect the measurement of the intraocular pressure. Since it is dependent on the cornea, so any change in the corneal thickness, biomechanics, refractive error, everything affects the measurement of intraocular pressure, including the scleral rigidity as well to some extent. So what do we need for a good tonometer? Well, we definitely need the accuracy of measurement, which is the most important factor. We want minimum variations in the measurement due to shape, thickness, and elasticity of the cornea. We want the least inter-individual variability, least affected by ocular and systemic conditions, and of course, we want minimal effect due to anti-glaucoma medications as well. So however, we are yet to find an ideal tonometer. And sorry, am I not audible? Okay. Okay. So, though we are yet to find the ideal tonometers, the gold standard for now is definitely a Goldman applanation tonometer, and we know that very well. Why? Because it is the most accurate so far, and the cost effective as well. It follows the Imbert fixed principle required to flatten a constant area of 3.06 millimeter on the cornea. The only prerequisite for that is an intact corneal surface, and patient should be able to sit upright on the slit lamp. There are methods to adjust for the astigmatic patient so that we can use the prism bars and convert the astigmatism to minus and measure so as to get the accuracy. However, there are certain factors that still affect applanation tonometry, that is the corneal variables, as I mentioned, including the refractive error. So these are the conditions where we actually cannot rely on GAT, and we have to do certain modifications or use other tonometers. Perkins is the next best, and close to applanation, best to use for children and patients who cannot sit upright or anesthetized patients. It is considered second best to Goldman applanation, and the IOP measurements are closely compatible to GAT. Tonopen works on Mackey mark principle, useful in corneal edema, scarring, irregularities, and even in infection, because we use a disposable sleeve which can be used. So all such kind of eyes we definitely used to need Tonopen. Rebound tonometer that works on a small plastic coated metal probe which is bouncing against the cornea and sends the induction current from which we deduce the IOP. And this is most useful in pediatric OPD because in children where we don't want to put topical anesthesia or they are not able to cooperate, this is a good tool to check in the OPD. It does overestimate the intraocular pressure as compared to GAT. Pascal DCT is something which can be considered ideal, but it is similar to GAT, but it is not depending on applanation. It is contour matching. It has a piezoelectric sensor which calculates the changes in resistance and gives us the intraocular pressure. It's supposed to be lesser dependent on CCT and corneal curvatures, but is not very commonly used because the probes are quite expensive. Also, the intraocular pressures are higher than GAT with particularly thinner and flatter corneas, so it takes care of those abnormalities. Schwartz is an age-old tonometer, no longer used though, but very extreme situations where we don't have any accessibility, measurement by Schwartz is also better than not measuring the intraocular pressure at all. Why it got unpopular was because of dependence on the ocular rigidity and high variability. There are certain tonometers which can take care of the biomechanical properties, and ORA is supposed to be the first one which could overcome the corneal biomechanics and gives us the accurate intraocular pressure. It gives us not only the intraocular pressure but also corneal hysteresis and resistance factor. So the IOPCC can account for the errors due to corneal biomechanics and may fare better in these situations where there is poor corneal biomechanics. And also parameters like hysteresis gives us the idea. The lower the hysteresis, the larger are the chances of glaucoma progression. The second best, or I would say technically the best for overcoming biomechanical properties is Corvus ST. It's a high resolution Scheimpflug camera which calculates the deformation amplitude by putting a constant force of air on the cornea. And BIOP is supposed to be the corrected one, which is useful. And also the other parameters like deformation amplitude do suggest intraocular pressure in situations like keratoconus post-cross-linking. The newer indices of biomechanics are also useful, like biomechanical glaucoma factor, which is supposed to be more useful for patients with NTG, as it is an early indicator of NTG patients, or where we have the normal intraocular pressures as such. There are certain tonometers which are like transpalpable against the tarsal plate, very limited use, maybe in keratoconus patients. Phosphine tonometer, self-tonometry, but its sensitivity to detect is very low, so not very popular. Triggerfish was a contact lens embedded with a strain gauges to measure the elasticity in the limbus due to change in the intraocular pressure. But it tells you about the relative changes of intraocular pressure and not the absolute intraocular pressure, considered to be good for 24 hours, but not so popular still. There are certain implantable monitoring systems like IOL probes, or certain AIOS studies tells you about the telemetric sensor which can be implanted during the cataract surgery and monitors the pressures throughout the day, but limited use because of the possibility of pupil distortion and uveitis. So basically, to select the tonometer for which patient, I would say for community screening, the Perkins, iCare and Tonopen fare better. All patients with intact corneal surface are able to sit on the slit lamp Goldman applanation tonometry for sure. For scarred and irregular corneas, you can use Tonopen. For patients under anesthesia or patients who cannot sit, or children, you can use Perkins. In regular clinic, children and patients who are not able to cooperate or are allergic to topical anesthesia, iCare or Rebound works best. And patients with poor biomechanics or corneal ectatic disorders or post-cross-linking or keratoconus, Corvus ST and ORA works better. However, we still have eyes like this where no tonometer can work better. Maybe there we have to depend on our digital IOP and other clinical parameters to estimate what is how much pressure we need to reduce. So with the knowledge so far, So with the existing knowledge, using appropriate tonometer for each situation for accurate IOP reading would help in managing glaucoma situations. Thank you for the patient listening.
Thank you, Sushma, for covering the topic so nicely. We'll take the Q&As at the end of the session. So now I invite our next speaker, Dr. Suhasini. She's going to talk on CCT and corneal hysteresis. And I also request the next speaker to be ready on the other side, Dr. Shalini.
Respected chairpersons and the audience, a very good morning. So my topic is on CCT and corneal hysteresis. So CCT and corneal hysteresis are two important variables. They can be even considered as biomarkers in assessing the risk and progression in glaucoma. So if you see the cornea, it has the physical property such as the corneal thickness and the curvature, and the physical behavior or the biomechanical behavior, which is the corneal hysteresis. Assessment of central corneal thickness have now become an integral part of the diagnosis of glaucoma in today's times. And lower CCT is a known risk factor for glaucoma, we know from the OATH study. For every 40 micron of corneal thinning, there's a twofold increase in the risk of developing glaucomatous optic neuropathy over a 5-year period. CCT can be measured using a simple handheld ultrasound pachymeter, and there are also other equipments which we have in the clinic, the optical biometer, the topographer, AIOS, which can measure the corneal thickness. Corneal hysteresis, what do we mean by corneal hysteresis? It actually reflects the ability of the corneal tissue to absorb and dissipate energy. So corneal hysteresis is akin to a shock absorber. The normal values range from 10.24 in some studies and 10.7 in others. And the most important thing is corneal hysteresis, it does not vary like IOP significantly throughout the day. So low corneal hysteresis means it has poor shock absorbing, the eye has poor shock absorbing capacity, which makes it susceptible to the damage because of the high IOP in terms of progression and predicting the risk. So the ocular response analyzer, ORA, is a very good instrument for measuring the corneal hysteresis. And it works on the non-contact technology, and where it uses applied force, and there is an electro-optical system which measures the applanation. So you have the right and left eye with the values of IOP-CC, CH, and IOP-G. So when the applied force, when the force is applied on the cornea, it causes applanation, the deformation. So that pressure applanation is called as applanation 1. The pressure at that point is P1. And then when the cornea returns back to its original position, the pressure reading at that time is the applanation pressure 2, or P2. The difference between this P1 and P2 gives the corneal hysteresis, and average of this P1 and P2 reading gives the IOP-G, and IOP-CC, corneal compensator, is where it takes into account all the corneal artifacts. So it has been shown that GAT and the ORA IOP-G show good agreement. So the other instrument used to measure the corneal hysteresis is the corneal Corvus-ST, as Dr. Shushma had told. It stands for corneal visualization Scheimpflug technology. This is also a non-contact technology. And actually the deformation and the geometric changes in the cornea are measured and using a high-speed Scheimpflug camera. And it gives a very detailed report, some 37 parameters with the latest version. It gives the biomechanical IOP, which is an important parameter. It doesn't actually give the corneal hysteresis value. And the deformation process is actually captured by this Corvus-ST. So actually low corneal hysteresis means diminished ability to dissipate energy in response to applied stress. Applied stress is the force, and the strain is the deformation that happens. So, and this makes it more susceptible to the glaucomatous damage. And low corneal hysteresis is seen in POAG, asymmetric POAG, PACG, NTG, PXF glaucoma, congenital glaucoma too. In a multivariable model, they have seen that corneal, it is corneal hysteresis and not CCT, which can discriminate between the POAG eyes and the normal group. CCT could be normal in both normal and POAG eyes, but corneal hysteresis is low in the POAG eyes. So corneal hysteresis can be considered a surrogate marker for glaucoma, a surrogate marker for ocular stiffness, for the lack of compliance and trab meshwork, the peripapillary sclera, and the lamina cribrosa. So in this study actually showed that low corneal hysteresis, but not CCT, was associated with progressive visual field loss. You can see in this diagram, when the corneal hysteresis is less than 10 mm mercury, the predicted visual field index values show a downward trend over time. But whereas on the right side, when the corneal hysteresis is more than 10 mm, you can see it's all in the horizontally maintained or shows the upward trend. This is another paper by Susanna et al. And they actually showed that the cumulative probability of developing glaucoma is more when the CH is less than 10.2, the dark line. So it is a risk factor for predicting glaucoma. And in the same paper, the hazard ratio was calculated for various parameters. And for CH, it was seen it's 1.21 with significant p-value, whereas for CCT, it's only 1.15 and not significant. This is a population-based study where there are 96 UK biobank participants were there, and the corneal hysteresis was measured in all of these people, and they found that low corneal hysteresis was significantly associated with a higher prevalence of self-reported glaucoma when the CH was less than 10. And this is a paper correlating CH with CCT, and the correlation was found to be strongly positive in normal eyes, in normal eyes, and moderately positive in glaucomatous eyes. There are factors which affect the corneal hysteresis, like CCT, age, diabetes, axial length, keratoconus, IOP. But then the fact of the matter is none of these parameters have been considered in any of the ORA studies. And medications also can affect the CC, can confound the CH value. So, for example, prostaglandin analogs induce structural changes in the extracellular matrix, and this results in low CH and can confound the significant association between CH and glaucoma. So now, should there be a historic change in clinical practice? So though corneal hysteresis is the only factor, parameter that measures the biomechanical property of the eye, still, and there is evidence to show that it's a strong risk factor. And there is instruments to measure the corneal hysteresis. Still, it's not widely used in clinical practice. So this is a question I would like to ask the panel. So we need to consider CH equal or at least equal to CCT because they have a role in glaucoma management and risk stratification. Thank you.
Thank you very much. That was a comprehensive view of both hysteresis and corneal thickness. I'd like to invite the real Shalini Mohan to give the talk on evaluating the ocular surface. Shalini.
Thank you so much, respected chair, and good morning, everyone. So today I will be talking about ocular surface evaluation in glaucoma patients. Can I have my presentation?
It's not visible. Dr. Shalini Mohan.
Dr. Medha, come to the dais only 1 minute before actually. Otherwise, you'll have to stand up for a long time. So
They don't know the timer.
They're
Timer
just
is not visible to all. Audio visual, do you have a buzzer or anything? Yeah, so 1 minute before the 7 minutes this thing, just give a one single buzz. So the speakers will know that 1 minute is left, we can come on the dais.
और अगर तुम में से एक यहाँ रहेगा ना बहुत अच्छा होगा क्योंकि ये बार-बार कल भी ऐसे ही हो रहा था कि चालू नहीं हो रहा था presentation. You be here so that you coordinating properly.
Yeah, thank you. So we understand that major concern with anti-glaucoma therapy is ocular surface damage, which is seen in 45 to 60% of patients which are on anti-glaucoma medication, which can be due to the primary drug or due to the preservative. It leads to poor medication compliance and also failure of anti-glaucoma surgery, which might be subconjunctival. So how can we assess ocular surface in our patients? It can be subjective by various questionnaires which are available, or it can be objective by variety of these tests, which I will be discussing. So OSDI scoring is very commonly used, which is 12-item questionnaire, and it is ranged from 0 to 4, and then patient has to answer these questions. And after this, it is multiplied by 12.5 and the sum of individual question scores divided by number of the questions which patient has answered is yielding a score from 0 to 100. So 0 being normal and 100 being the severe form of the dry eye. There are variety of simplified questionnaires also available which can be used to assess the subjective ocular surface diseases. When we talk about objective, the most important is tear film breakup time and very easily available to us also during slit lamp examination. So it is the time of appearance of first random black spot onto the surface of cornea. It is important that cornea must not involve an area of altered cornea, and we should look from limbus to limbus, and we need to take at least 3 readings, average it, and if it is less than 5 seconds, then it is definitely abnormal. So there can be a variety of patterns seen on TBUT. Fluorescein staining, which is used for TBUT, is also very important for assessment of integrity of cornea and conjunctival epithelium. It can also assess the volume of the tear film by measuring the meniscus height. But important thing is we should not use lubricant eye drops while doing this test because this may alter the result. Now, I find this Asia Dry Eye Workshop Society parameters very useful. In conventional method, we use blue filter, but because the blue light is reflected very highly from the surface of sclera, so it can give good assessment of corneal problems, but not good assessment of conjunctival problem. Therefore, with blue-free filter, barrel filter, we can see the conjunctival issues also, and therefore, we should try to use this. Now, this is a very important chart which I am showing. It actually helps us to classify which type of dry eye is there in the patient of glaucoma, and then accordingly you can treat. The first column you can see is of aqueous deficient dry eye, and the first picture you're seeing, it has very areas of break. If after the first blink you can see these areas of break, then it is definitely aqueous deficient severe form of dry eye. Whereas if you can see a line break which is visible in the lower photograph, then this is actually a kind of mild to moderate aqueous deficient dry eye. So you need to add on lubricants as per the patient need. The second column you are seeing is the mucin deficient dry eye. Here you can see these are the small spots visible into the area. These spot break are actually classic of poor wettability of the cornea, and in the inferior photograph you can see there is a dimple break. These are the vertical lines which are visible, which signify mild to moderate dry eye. Whenever there is problem with the lipid layer, it is increased evaporation, and then you can find random areas onto the surface of cornea, and therefore you can decide what is the type of dry eye in your patient. It also helps to delineate the various type of corneal pattern, and you can actually grade them depending on the dots you see onto the examination. The first picture you can see none. In the grade 2 is where you can see 1 to 15 dots. In grade 2, you can see 16 to 30, and if they are more than 30, it is grade 3. So depending on severity, you can increase the intensity of your treatment. Non-invasive breakup time is definitely better, which actually projects the rings onto the surface of cornea, but you need specialized machines for this. Tear volume assessment can be done by tear meniscus height, where you classify normal, reduced, or excessive, or you can do Schirmer's test, where you can see take up the Schirmer's strip, and if it is more than 15 millimeter, it is normal. If it is less than 5 millimeter, it is aqueous deficient. Try to keep the Schirmer's strip at the junction of lateral third and the medial third. So tear meniscus height can also be assessed on anterior segment OCT or by taking photographs, or you can see this strip which is used for meniscometry, but we don't use that commonly in our glaucoma clinic. So fluorescein is the best thing to be available to us. Now this is the lip cough, which is the conjunctival fold due to the rubbing of the eyelids onto the due to the friction, and the number and the severity helps us to delineate the severity of the dry eyes. Now lipid layer assessment is important. You can express with the help of COB evaluator, or you can pinch to see how much is the sebum. Otherwise you can do meibomography by infrared photography. Tear film osmolarity is important component which helps us to assess the inflammation, but that needs specialized instrument. So to summarize, I will say that evaluation of ocular surface is important for our glaucoma patients. We just not need to diagnose, but we also need to assess what is the type and what is the severity. And therefore, early recognition is important so that we can apply timely treatment which can improve the quality of life of our patient and improve the medication adherence. Thank you so much for your kind attention.
Thank you, Dr. Shalini, for a wonderful talk. This is something we often miss during our examinations, and this is a must for glaucoma patients.
Yeah,
now I call upon Dr. Medha Prabhudesai for her talk on critical elements of disc evaluation. Dr. Medha, please.
Good morning, everyone. At the outset, I would like to thank chairpersons and AIOC for giving me this opportunity. I'd be talking on critical elements of optic disc evaluation. You have to do a careful exam and keep an open mind while evaluating the optic nerve head. Clinical evaluation is the most overlooked skill because ONH signs have high sensitivity and specificity for diagnosis of glaucoma. We need a systematic approach which improves detection of glaucoma. Documentation can be done baseline with color and red-free photographs, and stereo photographs are preferable. Serial photographs are important because we can identify the progression at an early stage. There are various signs of glaucoma depending on these 5 categories. These are: determine the size and shape of the optic nerve head, evaluate NRR and its thinning, check for vascular signs, look for RNFL thinning, and examine the peripapillary atrophy. So before that, we should know how a normal ONH looks like. It follows the ISNT rule. A horizontal cup is much more than the vertical cup. There is variation in disc size in normal ONH also. So depending on that, the CD can change, and this affects the apparent neuroretinal rim. So what are the techniques? This is a gross technique with Welch-Allyn microscope. It gives in 5 degree aperture gives a 1.5 mm area and 1.77 millimeter square, and this is a slit lamp biomicroscopy scope where you can have a handheld lenses. A VOC 90D will give, if you multiply by 1.33 exact area of the disc. So how to identify clinically? So if you have a fovea centralis and optic disc size, and if you see how many diameters are there, if it is more than 2 to 2.5, you can say that this is a small disc. This is a medium disc because it is almost 2, and this is a large disc where it is just 1.5 disc diameters. So high CD, always large cups. They have large cups, so you need to investigate and do not label them as glaucoma. Physiologic cupping, you need to document and see if they are progressing. Myopia, obviously, it is a diagnostic dilemma, and you need to document and investigate. Tilted disc in myopia, always investigate. Tilted disc syndrome is there, where there is a bilateral inferiorly tilted disc, which is seen here. So this is a different type, and this is not glaucoma. Now identify NRR and staining. You need to identify the age of the disc, follow the course of the blood vessels, where they over the NRR, and identify the inner margin of the cup. Similarly, again, identify where the vessels traverse the optic nerve and identify the disc margin and NRR. Circumlinear vessels, usually they are on the inner margin of the NRR, and here it is easy to find out where the NRR ends. So disc asymmetry, unilateral in a large cup and large disc can be normal, but if the disc size is same and NRR is thin and large cup, should be investigated. Vertical enlargement of the cup in a vertical oval disc can be normal, but vertical cups and thin NRR along with RNFL defects can be glaucoma. So pallar cup discrepancy is a pathognomonic sign, and you need to identify these patients very carefully, especially if they have wedge-shaped RNFL defects where the notching is there. So cupping more than pallar, definitely glaucoma, but pallar more than cupping may not be glaucoma. Here you can see that it's a patient has a NRR pallar, and here we investigated, and the patient had something else which had with me underwent, he underwent MRI. Concentric atrophy and laminar dot sign can be seen because of loss of neuronal tissue. This is advanced cupping here. Check for vascular signs. This is a significant finding, that is a splinter or transhemorrhage. This can be first sign of glaucoma, and it is seen in NTG with large IOP fluctuations, and hence you need to monitor and need more aggressive therapy. Bayoneting is seen, there is sudden change in direction of when they come out of the NRR, and this is called as bayoneting. Bearing of circumlinear vessel is because of the loss of neuronal tissue here, and overpass cupping is also seen where the vessels suddenly dip into the nerve because of the loss of tissue. So check for vascular signs. NVD can be there, but this is disc hemorrhage. Bayoneting can be seen when the cups are deep, but this is glaucoma here. And circumlinear vessels, this can be normal, and bearing can be abnormal. So check for RNFL thinning. Here there are slit defects which can be normal, which may come and go, but these slit defects needs definitely your examine properly and document them. These are the wedge defects, superior and inferior pole, and diffused RNFL loss, so need to careful examine. So if you see the normal ONH and you cannot make out whether the NRR is there, so there can be a wedge-shaped defect which needs investigation. Peripapillary atrophy, alpha zone and beta zone is also important. Beta zone is seen in patients with POH and NTG, and hence needs to be carefully understood. So this can be myopia, but the other two can be glaucoma. So advanced or this thing, is it normal? This is a peripapillary atrophy, but this is definitely a physiologic condition, and you need to investigate, but not a glaucoma. Always watch for progression, because the disc hemorrhages can disappear and reappear at different stage, and they can precede the RNFL defects over there. Here also there is a progression of wedge-shaped defect and an inferior thinning of RNFL slit defect. Some discs are definitely outliers, and you cannot make out whether they have glaucoma or not, so you need to document them. So this is a patient, medium-sized disc, all the signs are there. Again, a left eye, all the signs are there. So these patients have glaucoma. Always, always document. Don't forget documentation of these patients. Always remember there can be comorbidities like PDR or ARMD because they are all elderly patients. Don't ignore large curves because they can be normal, can have advanced glaucoma, and can harbor something else that is a neurological condition. So always note the disc size. NRR is important and not the CD. Check for palmar cup discrepancy. Find and observe vascular signs. Evaluate RNFL defects. Note the signs of progression. Keep a high level of suspicion when the findings are atypical. Remember that a patient may have more than one disease, and keep in mind that everything that looks like glaucoma may not be glaucoma. Thank you for your.
Thank you, Dr. Mehta. It's a very important method for examination in day-to-day practice. Very extensive talk. Thank you again. Now I request Dr. Parul to speak on which visual field strategy we should use.
Good morning. I'll be talking about which visual field strategy to use. The visual field strategies and the test patterns on automated perimetry, they run in tandem. We are all aware of the common test patterns that we use for glaucoma. 24-2, 10-2, and in advanced cases, the macular test. I'll be focusing primarily on the Humphrey field analyzer. The thresholding strategies have evolved majorly from 1980s when we were doing full threshold to eventually to fastback and then CETA standard. And in 2010, we saw that CETA fast and has progressed to even CETA faster. So that's what we would be talking about. We are all aware about these common test patterns, so won't be dealing much with them. Let's have a look at CETA standard, which is the traditional testing protocol. It's a full threshold strategy. It tests the primary points twice, giving you an accurate result. There is a standard grid pattern of 6-degree spacing, but it's quite time consuming. And as the patients get older and the disease advances, they take a lot of time to perform a CETA standard, and many a times you start getting unreliable results. Maybe when you do the first eye, the result is reliable, but by the time you move to the left eye, the result starts becoming unreliable. So I think it's best suited for baseline assessments and detailed monitoring of visual field changes over time, but once the disease starts progressing and patients, they start getting older, you can switch to another strategy. Time to switch to another strategy is best when the patient is stable, rather when you suspect there is some amount of progression, because then you really need to stick to the primary strategy that you're using. A step over CETA standard is CETA fast, which is a faster alternative. It uses an adaptive testing strategy that focuses on testing regions of visual field more efficiently. There is an intuitive element with this test. If you are a smart tester, the points would be projected to you at a faster pace, and some of the points the machine will fill on its own. It sacrifices some amount of precision and coverage compared to CETA standard, but it's a reasonable compromise, and in busy practices, most people now have started using CETA fast. This too can be used for routine follow-up and examination and screening purposes. The usual test time is much less than CETA standard, so the patients don't really fatigue as much. Coming to the newer kid on the block, that is CETA faster, which is available with HFA3, it further optimizes in terms of testing speed while maintaining an acceptable level of accuracy. It builds upon the principles of CETA fast. The clinical relevant information you can get in 3 minutes, quite fast, but there is still a major group of glaucoma specialists who still don't really rely on glaucoma faster, because it does tend to lose accuracy when we are talking about patients where critical decision making is to be made, especially when we are focusing at the central spots. CETA standard double checks the sensitivity at each spot. CETA faster, it's 50% faster than CETA standard, as I've already talked about. It removes the unnecessary dead time during the testing. There are no blind spot or false negatives. Entirely, it focuses on the gaze tracker to assess the reliability. So this image shows the first one with rim defect of a patient who was repeatedly performing bad on CETA fast. He wasn't able to do CETA standard at all. Once we shifted to CETA faster, the reliability as well as the test accuracy, it improved. So for some patients, even if they are young, they are just not used to taking up a longer test. A shorter test can help solve. So coming up to 24-2 CETA faster, we need to understand what was the problem with 24-2, which the computing engineers pointed out. So 24-2 uses a 6-degree grid in which only 4 test points fall within the central 8% of vision, and it does not adequately sample the macular region, which is occupied by more than 30% of retinal ganglion cells. And we know that even in patients with mild disease, there are several defects in the central vision. So going a step further, we have CETA faster 24-2C, which has optimum test points from the 10-2 pattern, which were added to the 24-2 pattern. And so we now have additional 10 points which focus on the center and help you to pick up the disease at a much earlier level. So simplistically put, 24-2, all points are being tested. When we go to 24-2C, these points which are marked in red, these are dropped intuitively by the machine. And when we step ahead to 24-2C faster, the points marked green are also dropped. So we are actually compromising on some points to get a reliable response. So this elderly subject with the unreliable 24-2 CETA fast, he performed better with 24-2C CETA faster. And for the first time, the patient said that he felt confident doing perimetry. And every morning he had to come for the perimetry test. He was very anxious, but this test sort of reassured him that, he can also do the test reliably. The test time dependencies on the visual field status as well as the results which the 3 algorithms gave have been shown to be quite similar in several studies, and this was one of the major studies which showed that the confidence intervals, they overlap over a whole range of threshold values. Still, there is a limited value of 24-2C, because if you get 1 point which in the central zone which is abnormal, you are not going to start your treatment unless or until you have 2 or 3 contiguous points in 24-2C central area. Now that too is not really possible because the number of points in the central area is still lesser than what you would expect in a 10-2. So it doesn't really contribute much to your decision making. So if you were having a patient with early glaucoma with 1 or 2 points in the center which were involved, you wouldn't really start treating this patient. So eventually we all would go back to the old 10-2 to sort of get more clarity on that point. So where to use 24-2C in glaucoma staging is still unclear. You can switch your patients from CETA standard or fast to CETA faster when patients struggle with the fields, when they have lumbar issues, or if you want a more targeted approach where the central defects are suspected. But remember that there is a challenge. The mean deviation values improve when CETA faster testing is performed in a longitudinal setting. So you have to keep in mind when you switch the patients. With regards to progression detection, CETA standard is slightly better than CETA fast and faster, but with HFA3, now you can fuse the previous different form of strategies and get all the form of strategies in the GPA summary, which allows you clinical equivalence of testing. So choose wisely and choose to strike a balance between repeatability and reliability. Thank you.
Thank you very much for this wonderful talk on perimetry. May I please call Dr. Talveer Sidhu. She's going to talk to us on diagnostic gonioscopy.
A very good morning. I'm going to talk on diagnostic gonioscopy. So at the start, I would like to thank my teachers, Professor Ramanjeet Sehota and Professor Tanuj Dada. The first thing that we need to know is what kind of gonioscopes are we using? Is it a gonioscope which can be used for manipulation gonioscopy, or is it a gonioscope that can be used for indentation gonioscopy? Manipulation gonioscopy, it uses a 2-mirror Goldman type gonioscope, while the indentation gonioscopy uses a 4-mirror gonioscope, a Zeiss type gonioscope, where the well is smaller and it can be fit over the cornea without using a coupling fluid. Also, while performing gonioscopy, it is important that it is done in a dimly lit room, because if you increase the light in the room, the pupil will constrict and artificially open up the angles. Also, it is important to make yourself comfortable and use a hand rest. Instruct the patient to look straight while you are applying gonioscope over the eye. So while applying a gonioscope, the patient can be asked to look upwards. You can use a swab stick to retract the eyelid and put a gonioscope over the eye. It is important that the edges of the gonioscope is not chipped, because they can cause corneal or conjunctival abrasions. When you start the gonioscopy, it is important that you use a 2 millimeter small thin slit beam which does not touch the pupil, because if it touches the pupil constricts and artificial opening of angle can happen in people who have angle closure. It is also not a rule, but generally the superior angle is looked at first because it is the narrowest angle in the eye. If you press on the gonioscope too much in a Zeiss type gonioscope, it will cause corneal folds as can be seen in the picture, and it will lead to artificial opening of the angle because it pushes the aqueous into the angle. Also, when you do gonioscopy, it is important to form a pattern, and it is also important to follow a pattern. So the first thing to note is what is the posterior most structure visible. Is it the shawl base line, the trabecular meshwork, the scleral spur, the ciliary body band? So these are the structures that are usually visible in the angle. You ask the patient to look straight and see which area is visible. In an open angle, usually the scleral spur, here you can see an open angle, you are able to see the scleral spur, the trabecular meshwork and the shawl base line. Here also this is an open angle where you can see the ciliary body band, and the other angle structures are lightly visible. This is a closed angle where you are able to, where you cannot see any angle structures, and here you can see that there is some pigmentation in the angle, but is it the trabecular meshwork or is it some pigmentation that is present over the shawl base line? To decide that, we can use a corneal wedge technique. A corneal wedge is formed by the reflection of light on the inner surface and the outer surface of the cornea in the form of a U at the level of the shawl base line. So if any pigmentation is present at the level of the corneal wedge, it is actually present at the shawl base line. In an open angle, you will be able to see a corneal wedge, and following after that there is a straight line that is present. But in a closed angle where there is some pigmentation over the shawl base line, you can see that the pigmentation is actually forming at the level of the corneal wedge, and the other angle structures are actually hidden behind the iris. So this is a corneal wedge technique which can be used. So here you can see corneal wedge formation in an open angle and a straight line behind it. You can see a corneal wedge formation in a closed angle. There is no straight line behind it. You can see that the iris is pretty much hiding all the angle structures behind itself. The second thing to note is an angle recess. Angle recess can give you slight quantification, a subjective quantification of how much angle is visible. So this is the angle between the line on the cornea and the light line on the iris. So you can see that this is almost 40 degree in an open angle, but in a closed angle you can see that the iris is bowing upwards. That is why the angle between these two lines has decreased, usually less than 20 to 15 degrees. Iris configuration is also important. In open angles, you will see that the iris is usually lying flat over the lens. In closed angles, the iris is convex, it is bowing upwards. In some patients where there is concave iris configuration, the iris might be rubbing the zonules, leading to pigmentation release in pigment dispersion syndrome. After that, it is important to note what is the angle structure that is seen after manipulation. So in this video, you can see that the patient is asked to look towards the mirror, and when the angle opens up, the entire scleral spur is visible. Whereas in this angle, you can see some blotchy pigment is present inside the angle, and this blotchy pigment can later on lead to formation of goniosynechiae, where the iris sticks to the trabecular meshwork, leading to presence of goniosynechiae. Similarly, you will be able to see multiple goniosynechiae in people who have ongoing angle closure. Indentation gonioscopy can also be done, where you can press on the cornea and actually leads to opening up of the angle. So here you are pressing on the cornea and you can see the entire scleral spur becomes visible. So this is a indentation gonioscopy. Sometimes zipper angle closure might also be present in patients who have ongoing angle closure. Level of iris insertion may be different in people who have the iris lying flat, and the level of level of the iris insertion must be noted. Normal iris insertion is usually over the ciliary body or behind the scleral spur. In people who have juvenile open angle glaucomas, you might be able to see anterior insertion of iris, like over the trabecular meshwork or over the shawl base line. So this is a juvenile open angle glaucoma where the angle insertion is on the shawl base, on the scleral spur. In congenital glaucoma, over the shawl base line. Similarly in aniridia. Other abnormalities like increased pigmentation may be present in pigment dispersion syndrome. In pigment dispersion syndrome, a band-like pigmentation, fine pigment is present in the angle with posterior bowing of the iris. In pseudo-exfoliation, you will be able to see some whitish material and salt pepper-like pigmentation in the angle. Iris processes are also important to note. They are present in normal angles or sometimes increased in juvenile open angle glaucomas. They must be differentiated from goniosynechiae. Goniosynechiae usually do not follow the angle contour, while iris processes are finger-like and they follow the angle contour. Blotchy pigments and goniosynechiae are present in angle closure glaucoma. They warrant doing a YAG iridotomy. Uveitic glaucoma and Axenfeld-Rieger syndrome may also have goniosynechiae, but YAG iridotomy may not be needed in these cases. It's also important to differentiate normal angle vessels from abnormal angle vessels. Normal angle vessels are usually over the iris, whereas abnormal angle vessels are usually crossing the scleral spur and the trabecular meshwork. So here I would like to end with another finding which is seen usually in traumatic glaucoma, that is abnormal angle recession. Abnormal angle recession is widening of the ciliary body band, which can be seen in traumatic angle glaucomas. So it's important that when you have a patient who has an increased IOP, it is important to do gonioscopy in all these cases, because it will help you form a diagnosis. It might change your diagnosis. So always do gonioscopy. Thank you.
Thank you, Talveer. So I now invite our next speaker, Dr. Sushmita Kaushik from Chandigarh, to present her talk on when to use ASOCT and UBM.
Thank you, Chairs. Thank you, AIOS, for this wonderful opportunity. So this really is an eternal debate. There are no financial disclosures for the instruments that will be talked about, and I have taken informed consent from the parents of children who are recognizable. So UBM was really a new toy which came to us for angle imaging. We started work with the Paradigm, which sadly went out for a while. And then now we've got the Quantel, and since the last decade, this is the really go-to UBM, 50 megahertz, which we've been using. So with UBM came the wonder of in vivo histology, and I love this slide, which we've pulled out from our archives of a histology of angle recession, and on the UBM, in a patient, you could see exactly the same thing. So it really gives you almost a microscopic view of the angle and the other structures. Now, how does it compare to the ASOCT? They're fundamentally different. I don't think there could be a debate on when to use what, because they do completely different things. There are different indications, there are different uses, and the main use of UBM is to show what the eye can't see, which is behind the iris or the ciliary body, because it's using sound instead of light, whereas the ASOCT requires light to see. So if there's no light going in, the ASOCT can't see it either. So our exploration of the UBM in this short talk, we've looked at UBM versus gonioscopy and found no difference in the angle assessment. We could predict needling for failed blebs. We've looked for occult foreign bodies. We could diagnose unexplained intractable angle closures. And these are just some snapshots of the utility of the UBM that we've used in the clinic. So this, for instance, was a patient with unexplained hypotony following phacoemulsification, and the UBM showed us that there was actually a ciliochoroidal effusion. And I don't think any other investigation could have penetrated the sclera to show us what was going on. This was an intractable endophthalmitis which had undergone PPV but just wouldn't get better until the UBM found out that there was a metal piece which was embedded behind the iris, and you can see the back shadowing there. So this is, if you have an occult intraocular foreign body in the anterior chamber, the UBM can do that. This on the image on top shows you a laser iridotomy which is done, but the pressures have remained high. The angles haven't seemed to open up too much, and the UBM showed a plateau iris. You can see that anterior ciliary body there, and we realized that what this patient required was actually an iridoplasty, and you can see the iridoplasty has opened up and pulled out the iris from the angle. And sometimes if you have lumpy, bumpy irises and you just wonder what's behind, there's nothing like the UBM to show you these ciliary body cysts which are there, which are right behind. It's been a game changer in childhood glaucoma. We've seen so many interesting things, made it to the cover of some of these journals also, but of course we can image the Descemet stare very well. One of this patient actually had Axenfeld rigor where the iris was pulled over the pupil, and all we required to do was a simple pupilloplasty to just nibble that iris on top. And this, interestingly, was Peters anomaly where the lens is sequestered into a large corneal defect. So it characterizes the pathology in childhood glaucoma very well, and it also aids clinical decisions. This baby had a sudden ophthalmos following lens-sparing vitrectomy, and we realized that the UBM showed us it actually was a pupillary block angle closure. And interestingly, this patient, we've now looked at intracorneal clefts in childhood glaucomas, which we thought were Peters, and the UBM has helped us understand pathology better. And also conditions like congenital primary aphakia, where it would be absolutely lethal to go into the eye, the UBM shows us when there's no lens and we know when not to go in. Coming to the anterior segment OCT, it's non-invasive and it gives you high-resolution cross-sectional images of the cornea, the iris, the angle, and also the lens. The devices, as it has gone through, started with the time domain, like all OCTs. That was the Visante, and then went on to the Fourier or spectral domain, which you still can do on your Cirrus or a Heidelberg. But in the clinic, what we found really useful is the swept source 1310 nanometers, the Cassia, and that's a good, quick cross-sectional image of the angle and gives us a lot of, and the fact that it's so fast makes it very, very useful. The advantage, obviously, is that it's non-contact, and situations that preclude contact with the eye in case you want to do something the anterior segment, in anterior segment trauma, and to assess the extent of corneal or scleral injury in case it's there, a quick assessment of the angle as well. So just some snapshots of what we do in the clinic. So you can do an angle, anterior chamber, and corneal parameters if you want to really quantify them. If you're doing research, you're doing a thesis, and you want to measure, then the AIOS is of immense use. But remember, it's not independent of the operator. The definition of the scleral spur is the most important thing, and there you need a good operator or an accurate depiction of the scleral spur. Only then the AIOS will be able to give you quantifiable images. This, for instance, is an angle closure with a thick lens. The second image is after an iridotomy, and the third is after your cataract surgery. So you can see the progression of the angle, and if you want to measure it to do something, you can. Sometimes you can have lens subluxations where the pupil is you're not so sure of the lens, so this shows you this irregular angle closure. There are mechanisms other than pupillary block, like a large lens vault, that gives us a decision maker of when to take out the lens in a primary angle closure. And of course, I've shown you that in the UBM, but with the Cassia, even the ciliary body effusion can be visualized very well. You can visualize the blebs reasonably, and sometimes if you really want to see the tube there, so the AIOS is very useful as a quick thing of knowing where the tube is underneath the sclera. Sometimes it retracts and you want to see the position. I can't not talk of babies, so we have characterized the anterior segment using, we call this a flying baby. You can actually characterize the angle, and we've learned, can I take 10 seconds more? Yeah, okay. So we've learned that in a normal angle, this is what the trabecular meshwork could look like. This is unilateral PCG. That's the right eye. And look at what a dysgenetic angle looks like. There's no clear trabecular meshwork visible. And I'll just end with this wonderful case of sometimes these babies they all come to us because of our pediatric glaucoma clinic and diagnosed as PCG, but there's no ophthalmos. The intraocular pressure is normal. And the AIOS shows a clear trabecular meshwork just like in a normal eye. So we stepped back and we said, could this be a very, very early neonatal onset shed? And the genetics showed up that it was shed. So now we can use the AIOS even as a distinguisher between PCG and shed, which can be difficult at times. So imaging devices are not with their limitations, but you need to use them in the context of your clinical examination, as for all devices. Thank you very much.
Thank you, Shushmita. That was a great overview of the different applications of anterior segment OCT and UBM. Thank you. I'd like to invite our next speaker, Vineet Sehgal from Delhi, to give us a talk on the importance of ocular blood flow and OCTA.
Thank you, sir. So first of can I have my slides, please? So first of all, I thank the scientific committee who have given me this opportunity to be on the dais, and I would be talking about the OBF and the OCT angiography. So we have a lot of things with us. We have HVF, OCT, gonioscopy, disc photography, UBM, and now we have color Doppler imaging as well as we have OCT angiography. So whether they have added to our diagnosis or it has added to our confusion, we still do not know. So in my presentation would be in two parts. So first part, I would be talking about the color Doppler imaging, and the second one, I would be talking about the OCT angiography. Before I start my presentation, a brief outlook of what the ocular blood flow is. So the main artery is the internal carotid artery that gives rise to ophthalmic artery, and we have the short posterior ciliary arteries as well as the central retinal artery, which basically form the blood flow to the optic nerve head. So where OBF analysis may have a role. Three roles that is there. First is in the patients of glaucoma, those who are normal tension glaucoma, or the patients of primary open angle glaucoma where there is a progression even on normal intraocular pressure. Second is the patients with ocular ischemia, and third is the vessel occlusion. So my favorite is detecting the underlying undiagnosed systemic comorbidities in the patients with ocular history. I would just show you two cases. So what is the protocol? The patients come to us, they are diagnosed as either POAG or NTG. We go for a 24-hour BP monitoring, and then we consider it them for the OBF study, and then we complete the triangle with the cardiologist. So it is a cardiologist, radiologist, and ophthalmologist who are working in tandem. So first talking about the color Doppler imaging, we all know it's a non-invasive method. What we measure the ophthalmic artery, central retinal artery, and the short posterior ciliary arteries. We measure some parameters like peak systolic velocity, end diastolic velocity, and resistive index. So that is how the radiologist is doing the color Doppler imaging. Basically, it's my learning which I am doing for last 8 years. I have done it for almost all type of patients, trying to get some normative data, trying to get some baseline. So this is the report that we give to the patient. And as you can see below, we always give as impression what the radiologist thinks when he is doing the color Doppler imaging about the patient. And whenever we do a ocular Doppler, we also do a carotid Doppler. So we have different waveforms for the ophthalmic artery. Here, as you can see in the ophthalmic artery, there is a systolic peak, dichrotic notch, and a relatively little flow in diastole. Different in the patients with central retinal artery, where there is a rounded systolic peak, and different in the short posterior ciliary artery, where they have a blunt systolic peak and a low to moderate flow in the diastole. So two cases I would be talking. First one is a 74-year-old gentleman, pseudophakic. After cataract surgery, the patient is still saying that, sir, I am having blurring. Usually in a corporate practice, they are sent to the glaucoma clinic, and we saw everything was normal. I just went ahead with the ocular Doppler, and then I got a call from the radiologist that some abnormal vessels are being seen here. So what to do? The radiologist told me that, okay, I am going ahead with the carotid Doppler, and in the carotid Doppler, you can see there is a 100% blockage of the internal carotid artery. So going back to the slide, so we are getting some aberrant vessels, and due to that, we are getting aberrant waveforms. So that is how we diagnose something different when we are doing an ocular Doppler. Case 2, similar patient, after doing a cataract surgery, there was a pressure of 24, referred to the glaucoma clinic, everything was almost okay. We went ahead with the ocular Doppler, and there was no detectable left short posterior ciliary arteries. Here again, there was the internal carotid artery, there was a plaque, and there was a blockage, stenting was done. And post-stenting, when we did the ocular Doppler, we can get some flow in the short posterior ciliary arteries. So to the best of my knowledge, this is the first case where we have seen that there was post-vascular intervention, the patient had some flow in the SPCAs, but the problem is that the patient is having the same ocular complaints even after that. So what is the way ahead? We have to see how this technology goes ahead, and is there any drug or any intervention which we can do which can increase the ocular blood flow. Coming to the OCT angiography, it is also non-invasive, uses the principle of motion contrast. It calculates the vessel density, which is basically basically defined as the area occupied by the vessels divided by the total area. So we have radial peripapillary capillaries that are seen in the nerve fiber layer, and the superficial plexus that is seen in the ganglion layer. So the advantage of the OCT-A over the FA is that we can see the capillaries better here as compared to a patient with where we do a FA. So we get a printout like this, where there is a vessel density map, heat map, and the various indices. So that is how we see the optic nerve head radial peripapillary capillaries and the macula superficial plexus. The optic nerve itself is not a very good indicator because of the variability of its structure, and the superficial big vessels, they basically have a shadowing effect over the deep vessels. So here is the OCT angiography providing us something more. So OCT angiography with the various studies, we have seen that they are basically not having the vessel density index lower in those patients where the OCT RNFL thinning is also there. But they are better in the patients where there is an advanced glaucoma, where VD index would be better as compared to OCT RNFL, because we know the floor effect is there. It has also been seen in few studies where there is a disc hemorrhage. It can tell if there is a progression. There also, as you can see in this picture, that there is a progression which is seen with the serial OCT scans. Before I end my presentation, we have identified a biomarker also, where there is in the beta peripapillary zone, there is a total devoid of any vessels, where we can say that yes, it can be a biomarker for the future progression of glaucoma. Here also the limitation is there is no normative data, and vessel density is significantly affected by the signal density. So better is the signal density, better is the vessel density. So take-home messages: OCT angiography might be useful in the identifying glaucoma progression, and can be used as a biomarker for identifying future risk of progression. My last slide is circulation around the optic nerve head is still complex and might need more in-depth analysis, and both color Doppler imaging and OCT angiography cannot be used as a single modality of treatment. Thank you.
An excellent talk, Dr. Vineet, and I think this is the more upcoming part of glaucoma management, and maybe the audience will have many questions for you later on. So now I call upon Dr. Sushmita Kaushik again for her talk on digital workflow for diagnosis and management of glaucoma. Dr. Sushmita, please.
Sorry, I didn't know they weren't the speakers. Thank you very much again. This was a digital workflow. I thought this is something which we do every day. So it's not going to be very theoretical as what is possible, but I'll just touch upon how we work in our crazy clinic as we do. No financial disclosures, alas, though I'd be talking so much of Forum and Zeiss. So what is a digital workflow? What is possible? And like I said, snapshots of use in an everyday clinic. So in glaucoma or retina or cornea nowadays, you know that we have dozens of digital imaging modalities, and we use them to diagnose, we use them to monitor, and we also use them to document treatment effects. So the DICOM revolution has really helped. The DICOM is a digital imaging and communication in medicine. That's what it means. So this is the usual flow. We enter data, the optoms do all the measurements that they want, then the clinic is, of course, they're registered, they're archived, and then the DICOM sends out these images to the clinicians who are sitting in their respective areas. And for instance, for glaucoma, you'll have an OCT, you'll have a visual field, you'll have a disc picture, and then by the time the patient comes to you, hopefully on your screen, you have all of these, and it helps you make an informed decision of what needs to be done when the patient is in front of you. So that's in a nutshell what usually the DICOM is used for in the context of glaucoma. So an example is the Forum, which is what we have, which is by Zeiss. You can have interactive visual field data on one machine. You can have many, many fields which you can alter. If you think that some fields are not good, you can take them off the grid. If you think that an intervention has been done, you can reset baseline, so you can do a lot of things. You can do structure and function GPA by the Cirrus OCT and the visual field, the Humphreys analyzer if you can. And you have structure and function reports, which includes 24-2 as well as 30-2. A caveat of this is if you have a very, very busy clinic and hundreds and hundreds of patients, your machines can't incorporate them. So what is usually done is they are sent out into the server. If you don't have data in your machine, you cannot do a structural GPA, which is why that is a limitation of space and the limitation of having humongous data on an OCT machine currently. So most very, very busy clinics will not be able to have a structured GPA, so keep that in mind. So in the clinic, for instance, now you have this 84-year-old normal tension glaucoma, pressures of 14, advanced glaucomatous optic neuropathy, also wet AMD, and bilateral TRABs done. So when this patient comes into me, what are the two questions? Is this pressure okay for him, and how can I help? So we open the forum. So then what happens is you have all your patients here, then you put in the number, then all his investigations that have been done over so many years opens up, and then you open up today's. And today's you have visual field, you have GPA, you have the OCT, you have the single field analysis, so you have all these pictures which are there at you. Now you want to concentrate on what's he like when he came. So I scroll down and I realize, oh, this is what he was when he came in. So when he came in, he was as advanced as this, which is like 15 years ago. So you tell yourself, 15 years ago, this is what he was, and then the TRABs have been done, and now, so far so good, this is how he is. So pretty much stable, and he's doing all right. Now that the surgery's been done, how do we interpret the GPA? Because it will always, always show up as progression from the baseline. Whatever you do, this patient is always going to be worse than what he was because the GPA, remember, compares baseline to today. So how do you know after you've done surgery? Is there something you can do? So what we can do is we can mark it. So we mark the baseline as the point at which we've done surgery, and Zeiss allows you to put a little knife there to tell you that you've done surgery, and the rest of the GPA will then be computed from the second baseline. So that's the interesting and the useful thing that we can do. Well, surgery in the right eye, I don't think it's too visible. The visual fields had worsened. Now you're wondering what has happened. Why have the visual field in the right eye worsened? So you can see that the rate of progression was -2, and when you did surgery and after that, the rate of progression is -4. And then you're looking at yourself and you realize the culprit is the macular edema. So that is also there on your digital workflow, and then all you do is give a call to your retina colleague and say, hey, you know, this guy needs an anti-VEGF or something. And then he comes the next time, the macular edema is better, and then you can ask for another visual field and do it. So you can all do this while sitting in one chair and all your DICOM images coming to you. Another typical clinic flow would be a 45-year-old PACG, best corrected vision 6/9, IOP 32 and 30, and laser iodotomy is patent. Now the question is, how bad is the glaucoma? What are the discs? What are the fields? And is the lens a problem? She's only 35 years old, or 45 years old, and she has patent iridectomies and yet 30 pressures. So order tests, do the same thing, open up the forum, look at, so this entire thing will open up to you, and you can see that the discs are okay, the fields are not too bad. So the next question is, why is the pressure so high? Is it the lens? And then you look at both of them and you realize that the lens vault is more than 1,000 microns. So you think this patient probably needs an early cataract surgery. And once a cataract surgery is done, you realize that the angles have opened up and the pressures come down to normal. So you can open up the pre and you can see the post and you realize, okay, so this was the problem. So it helps decision making. Currently all is well. Fields are still fine, pressures are under control, discs are okay, and hopefully she'll remain okay for a couple of years too. So this really improves efficiency. I think it saves time. Decision making is easier because we have everything on one computer rather than looking through and sifting through lots of paper, and follow-ups have better visualization. Thank you.
Thank you, Dr. Susmita. As usual, a very wonderful talk, very extensive one. Now, may I request Dr. Angaraj to speak on role of AI in glaucoma. This is a new topic. Please, sir,
Yeah.
Angaras.
Thank you. So I'll be just highlighting some experience we have on artificial intelligence in glaucoma. And I want to, this is a disclaimer, I'm not an expert, but someone who is deeply interested in AI and its potential applications for the future generations and our patients. And I always feel, all these automated systems perform tasks which are needing kind of human intelligence. Somewhere our intelligence is so important because it mimics the cognitive functions associated with the human mind by learning and also solving the problem. I'm sure you've been hearing all these terms day in and day out, but basically, you're trying to do something like you teach the machine, it learns, and then it also deep learns, because that's the subset which happens internally, wherein you can always think that it's something like a glorified statistics, but the computers are so smart these days, the supercomputers, which can really deep learn a lot of things and give valuable information to us. So whenever we talk about machine learning, there is supervised and unsupervised. I know once you start Kolkata, search Kolkata, you get Rasagulla to everything, where it is not guided by the correct inputs. But if you guide with the correct inputs, and if you make the machine learn properly, if you put the right information, then you're going to get very valuable results. But if you're going to put garbage inside, I'm sure garbage is going to be outside. So why do we need? I'm sure you all know the problem of glaucoma, 112 million in the year 2040. And more than that, many of them are not aware. So we need to find ways where we can detect more people and start managing them at much early stage. And you saw all these investigations. I mean, there are so many equipments involved to clinch a diagnosis of glaucoma. So this is the problem with the screening. There is no single screening test. There is a mismatch between the population to ophthalmologist, and we are finding best ways to screen so that we can detect early. But still, opportunistic screening is the best. And there's a lot of problem in specialty training and all that. So how AI can help at this point of time? It can classify whether it is glaucoma or non-glaucoma. It can also identify the progresses, especially the quick progresses, quickly. And then it can also study some of the risk factors and, of course, quality of life. So if you take AI in glaucoma, as I talked, there may be several work happening, but it can interpret fundus photo. It can identify the progression in visual fields. It can interpret your OCT, because you have DICOM, you have electronic medical record, you have all the information like what Madam Sushmita was showing. If there it in your system, it can do a lot of interpretation for you and also do this very important structure and function correlations. So I'm not going to the detail, but it's basically the convolutional neural network framework which happens, and it can beautifully classify glaucoma. It is trained, the CNN model is so trained, it can detect between a cat and a dog. It's something like that. It can start differentiating between a normal and a glaucoma once you start training it. So there are several papers which are listed like this, and there are beautiful survey and review articles on artificial intelligence in glaucoma. But basically, many of these papers are with the optic nerve head, but now we have a lot of papers coming on visual fields and OCT interpretation. And all these papers show a very good accuracy of machine over human also. And this is a big list of papers, as you see here. But basically, we actually wanted to do a lot of work in the base hospital, but we also wanted to see how this really helps in our vision centers which are working in the rural areas. So we tried to see how we can incorporate this into our vision centers. So these vision centers are small primary eye care centers in a rural area which are run by ophthalmic technician and an optometrist, and they screen roughly 1 million outpatients a year. In 2023, we saw almost 1 million outpatients, and most of them had glaucoma screening. So what we use is the fundus on phone. There's no commercial interest. It's a Remedio camera with their offline AI, which can do DR, glaucoma, and ARMD in one shot. So the optometrists take a beautiful image, and they do this. And it also analyzes for glaucoma. And what it does basically, it can also look at your cup to disc ratio, and also it highlights the areas of concerns. No, it's got a heat map which goes into the RNFL defect and vessel changes and all those peripapillary changes which happens. And it takes a holistic approach like a human, not only on the disc, something around the disc, and then it comes to a conclusion, and it can be reported and it can be uploaded into your EMR for future telemedicine. So what we did was we compared AI with our Vision Center consult doctors. These are people who are our residents, the final year residents. And when comparing artificial intelligence to our residents who are trained in glaucoma, the specificity you see is 98.6, but the sensitivity is very low. And if you see AI versus glaucoma glaucoma specialist, these patients were brought to the base hospital. We had very good sensitivity and specificity. So when comparing to somebody doing a telemedicine, a junior doctor or a resident doing telemedicine, the AI did a very good job. And more importantly, the AI also helped the telemedicine doctor to learn better. Now, when the AI could detect something, the telemedicine doctor was carefully looking at it and saying, oh, I missed this defect, oh, I missed this changes, or the subtle notch which the AI was able to pick up. So there are a lot of limitations. I said if you put garbage in, you will get garbage out. Now we are concerned about whether it is going to de-skill us. Now we are going to be worried about artificial intelligence in the futures. But definitely, no, I think we are in a kind of crossroads. But we really believe that it's going to enhance physicians and provide a better care. At this point of time, no, if you put all these data properly inside, you will get to detect glaucoma and to identify progress. But the future is so bright. No, if you have very good electronic medical record and if you collect the correct information in the form of clinical data, genomic data, lifestyle changes, knowing the risk factors, and of course the medical history, we can definitely say the risk analysis, we can find the best management protocols, we can predict the surgical success rate, and also find the accurate prognosis for the patient. Thank you.
Thank you very much, Dr. Venkatesh. I'm sure we'll have more of AI in our lives as we go along. And I'd like to invite Dr. Sanjay Asrani. He's going to talk to us on OCT for diagnosis and progression.
Thank you, Vinay. Thank you, Vinay. I presume the mic's working and you can hear me back there. Thank you. This is how my patients feel when I tell them that you have to undergo a visual field test at the next visit. So relying on OCT to make a diagnosis and to monitor for progression is a way of influencing people and making friends. Your patients will not hate you, and we have a direct correlation. The patient who has been told that you'll get a visual field test at the next visit, they decide not to come typically at that next visit. So let's look at establishing a diagnosis. The commonest place where people want to look is what I call kindergarten level OCT. Is it red? Is it green? Is it yellow? I mean, we can rise above that. We need to look at the least colorful part of OCT, which is right here. It is the asymmetry between the two eyes, and that is going to tell us where the problem is. We can also see the nerve fiber layer defect on the red free. We can see the loss of tissue here. And last, we come to the normative database. We have been used to looking at cup to disc asymmetry. So when we look at the cup to disc asymmetry, we realize that there is a significant difference between these two eyes. But remember that the OCT is the only modality, or the OCT printout, I should say, is the only modality that eliminates the presence of the nose between the two eyes. It can bring these two discs side by side. You know, when you examine one eye, by the time you cross the nose and go to the other eye, you've forgotten what the size of the cup and disc is. So this is the only place you can see how that there is a difference in the size of the disc. That's why there is difference in size of the cup. Of course, the OCT will tell you that it is all normal. Once again, I want to remind you, look at the least colorful part of OCT to confirm that it is indeed symmetrical. Now, macular thickness in glaucoma and normals was not known until the late 90s. It was only in the late 90s that we created an instrument called the retinal thickness analyzer, which was the precursor of the OCT, that allowed us to look at normal retinal thickness and retinal thickness in glaucoma. And the only paper that I could come across was Van Buren's paper on the description of ganglion cells from 1960. There was nothing else written since then on the effect of the glaucoma damage in the macula. Fast forward to spectral domain OCT. This is the map you see typically in spectral domain OCT in the total macular thickness. Mind you, this is not GCL, IPL, all those other alphabet soup. This is total macular thickness. Why? Because it is very easy for the algorithm, software algorithm, to identify the ILM or the inner limiting membrane and the RPE, because they are the two most reflective layers of the retina. So the total retinal thickness is a perfect surrogate measure of the loss of tissue. And besides the loss that occurs with optic atrophy and many other cases that I showed yesterday, glaucoma is the predominant cause of loss of retinal thickness. So we did not have a normative database when we created this thickness map. We had to create this thickness map from scratch. You may realize that we are measuring this in the form of 61 cross sections across the posterior pole. Why 61? Because in 2009, that was the total capacity of my hard drive. I couldn't measure more. So since then, it has been 61 lines in the posterior pole. But we didn't have a normative database. So we took advantage of the same thing we always look, symmetry. Symmetry in nature, therefore macular thickness is also symmetrical, and therefore any asymmetry is very easy to identify. If you look at the asymmetry, you get a display. Sorry, that thing is not wanting to stay, but we'll show you more. You get a display of the difference between the two eyes. The nerve fiber layer circle scan, and by the way, the images that I'm showing you are from the Heidelberg machine, and I do not have any financial interest with Heidelberg engineering. The circle scan right here shows you everything is normal. But that's not telling you everything is normal. It's the average of that quadrant that is normal. That's why you have to look at the raw scans. You have to look at the focal loss. But it is easy to miss, isn't it? Because naturally, we are all going to go to the kindergarten level when we've got hundreds of patients. We're going to see where it is green, where it is red. But if you look at the macular thickness of this same eye, it's not going to be easy for you to miss this loss of tissue that is corresponding to the nerve fiber layer thickness. Now let's look at a complete example. You can see in this case, there is a loss of nerve fiber layer, there is a loss of thickness, there is a loss of macular thickness, and you can see that there is a superior paracentral loss. Now, there is also a normative database that allows you to see what is the loss of nerve fiber layer compared to normal and loss of ganglion cell compared to normal. Here is an example of a asymmetry between the two eyes, and you can see that there is an arc-like asymmetry in the right eye, indicating this very subtle thinning. On the 3D reconstruction, you can see the gutter here of the nerve fiber layer defect, which is right here, and you can see it on the color image. And the best value you realize of the OCT is when in the morning your staff tells you that the OCT machine is not working. that's when you start getting panicky. How are you going to go through your day? We are so dependent on the OCT machine. But there are some clinical skills that come to save the day. For example, you see how these blood vessels are dipping in and dipping out? That is one way to identify where the nerve fiber layer defect is. So you have to look at the blood vessel. If it is dipping in and dipping out, of course you need a dilated exam for that. How do we use OCT for progression? We use this clinical profile. We look at the pink area, which is the change from the baseline. We look at this loss of tissue and confirm that indeed it is loss of tissue that is happening. Mind you, it's all green. So if you go with that green level, you're not going to find any change. It's here, you can see it. Can you look at the macula simultaneously? Yes. You can see the baseline measurement, subsequent measurement, only 5 months later, and you can see a huge loss of macular thickness that is happening both superiorly and inferiorly. What is the cutoff that I use? Numerical values. For the sector value, I use 10 microns because the standard deviation is 4, so 2 standard deviations 8, and we round it off to 10. So if there is a 10 micron or more difference, there is a likelihood it is real change. Mind you, I want you to notice the global RNFL is not changing even. So global RNFL gets completely muddied by the effects of the other sectors. You can see, for example, progression using the OCT, using the cirrus. The best strategy, if you do have the cirrus, is to use the PanoMap, which is the entire area of the retina, because then you can correlate the RNFL and the macula. This is with OptoView, a similar type of RNFL analysis, GCC analysis, and you can get a slope also. Now, here is this same patient that I had started to show you getting worse despite the best care I can give. You can see the macular thickness loss happening. You can even look at the inferotemporal thickness loss going down with time. But you see this part up here? What is that? Did that patient regrow their nerve fiber layer? Yes. See this loss of nerve fiber layer? See, thickness is grown back. How can that be possible? It's very simple explanation. It's a disc hemorrhage that causes a thickness increase in the nerve fiber layer. Now, there is, in this example, you can hardly see any change happening. You can see maybe there is a small change out here. So you zoom in and you see that there is a small, very, very small change out here. But because it is on the superior slope or sometimes on the inferior slope of that main peak, you have to look at the macular thickness. And then you see that there is a definite arc. So that small loss there was real. It is glaucoma, getting worse. In normal pressure glaucoma, the classic changes happen more towards the temporal part, like right here. You can see it is more towards the fovea. It is right in the middle of the posterior pole and not in an arc-shaped loss in the high pressure glaucomas. In patients with the epiretinal membrane, you can still see an arc-like loss. You can ignore the distortion that happens. And remember, this machine does give fake news too. This is complete absence of nerve fiber layer in one quadrant. 2 minutes later, you take the image again, and now complete normality. This happens because the technician was not taught to bring the image into the middle of the window. And then posterior vitreous detachment, as you can see, is pulling on the nerve fiber layer. And unfortunately, the 3.4 millimeter circle is right on the same area where the Weiss ring happens. So when the vitreous pulls, the nerve fiber tissue may appear thinner. Like in this case, you see nerve fiber layer thickness is getting lesser, but there is no change in the macular thickness. And that's because the vitreous has been released. I'll skip this example, but this one I do want to share. This is how I learned to cure glaucoma in my spare time. This is a patient who came in 2010 with complete loss of nerve fiber layer. In 2012, the patient had regrown all their nerve fiber layer. How does that happen? Uveitis. Uveitis causes swelling in the nerve fiber layer. So if you catch somebody in the stage where there is active uveitis, what you see is a small cup is not real. What you see as a normal nerve fiber layer is not real. Now you start treating the uveitis and the cup starts increasing and the nerve fiber layer starts getting thinner. And that's because the edema is going away. That's why the field doesn't change. So in conclusion, don't accept the software's interpretation or stability of stability or progression. Confirm. Examine the raw image. It takes time. We owe it to our patients. Look at coexisting pathologies. Rule out vitreous mischief. Confirm changes of the nerve fiber layer on macular thickness. And repeat measurement if you're not sure. Extreme caution if you are going to use OCT in uveitis, and be aware of non-glaucomatous patterns of change. Thank you very much for your kind attention.
Thank you, Dr. Sanjay. It was a very nice and enlightening talk. Now I invite Dr. Monisha to give a talk on practical utility of genetic testing in glaucoma.
Hi, good morning, everyone. So we're going to shift gears slightly from diagnostics of clinical evaluation and imaging to glaucoma genetics. Okay, so this is the outline of my talk. So I'll start by highlighting the differences between single gene or Mendelian diseases versus complex disease, because this forms the basis of clinical evaluation and genetic testing. So as we know from twin and family studies, glaucoma is a highly heritable disease with genetic predisposition. And glaucoma can occur at all ages, and it exhibits both a single gene or Mendelian disease inheritance pattern as well as a complex disease. So what's the difference between them? So now single gene or Mendelian diseases are rare, and in here there is a single genetic mutation is sufficient to cause disease because it has a large effect size. And these genetic mutations can be passed on from the parents, and children can potentially develop the disease. So they do follow a Mendelian inheritance pattern of autosomal dominant, autosomal recessive, or X-linked recessive. Now, complex diseases, on the other hand, are more common, and here a single gene is not sufficient to cause disease. Rather, there are multiple genetic variants, and sometimes in combination with environmental factors that combine together to collectively result in disease. So a genetic variant is a point in our genome where we differ from one another. So now, early onset glaucoma, they follow the Mendelian inheritance pattern, and genes for them are identified from family-based linkage studies. Now, adult onset glaucoma, on the other hand, they are common diseases, and the genes for them are mainly identified through large-scale genome-wide association studies. So early onset glaucoma encompasses primary congenital glaucoma, juvenile open-angle glaucoma, and developmental glaucoma. So primary congenital glaucoma occurs in infancy. They're mainly sporadic. However, familial cases with autosomal recessive inheritance have also been described. JOAG, on the other hand, occurs from the ages of 3 to 40. They follow an autosomal dominant inheritance, and the most common gene implicated is the mutations in the myocilin gene. Now, Axenfeld-Rieger's and aniridia are examples of developmental glaucoma, and they have an autosomal dominant inheritance pattern. Now, adult onset glaucoma, like I alluded to, the genes for them are mainly identified through genome-wide association studies. There have been a lot of them for POAG, and to date we have over 300 genetic loci that have been associated with POAG. Now, PSEG, on the other hand, is less well studied. We currently have 8 genetic loci associated with PSEG. So we know all these genes. How does this, what are the implications of these glaucoma genetic variants? So again, this is different for early onset and adult onset glaucoma. So in early onset glaucoma, because these are single gene diseases, there are gene-based tests for diagnosis of disease. Now, adult onset glaucoma, on the other hand, as I said, the genetic variants on their own are not sufficient, they're insufficient to cause disease. Therefore, what happens with them is they can be, the effect of these different genetic variants can be evaluated together in order to compute what is known as the polygenic risk score. So this risk score is a number, it's a percentile, which is between 0 and 100, and depending on what the percentile is, you can then interpret it as whether it's high, moderate, or low risk. So a polygenic risk score, basically, it's a quantitative summary of a person's individual genetic risk for a particular disease or a trait. So an individual can have different polygenic risk for different diseases. The same individual, different polygenic risk for different diseases. So in this paper from Jamie Craig's group, which was published in Nature Genetics in 2020, they described the development of the polygenic risk score for glaucoma, and what they had utilized a multi-trait GWAS analysis of not just glaucoma, but also the genes for cup-disc ratio and IOP. And they looked at the performance of the polygenic risk score across different glaucoma outcomes, such as the age of diagnosis, the change in RFL, and the likelihood of trabeculectomy. And what they found was patients that had the highest polygenic risk score, they were diagnosed to develop glaucoma earlier. And they also found that with every decile change in the polygenic risk score, this was associated with an accelerated progression rate on the RNFL change. And also patients with the highest genetic risk score were more likely to have undergone trabeculectomy surgery. They also looked at a prediction of genetic risk score, and what they found was that those patients with the highest genetic risk score had a 15-fold increase in the risk of having advanced glaucoma. And when they incorporated these polygenic risk score into as a prediction for development of glaucoma, they found that it increased the predictability over and above that was obtained by traditional risk factors of age, gender, and family history. So glaucoma polygenic risk score is a new approach which can potentially facilitate development of personalized management by identifying those patients who are at increased risk. But however, we know that most of the GWAS studies were performed in patients of Caucasian ancestry. Therefore, the applicability to other ancestries, non-European ancestries, are still being evaluated. So how do we translate what we know of these the different scores or these genes, monogenic diseases, into clinical practice? Again, this is different for early onset glaucoma and for adult onset glaucoma. So what the AAO recommends for inherited eye diseases, which includes early onset glaucoma, is that it is only warranted if it will impact treatment or surveillance. So for example, benefits of genetic testing are for those family members so you can plan appropriate surveillance for those family members who carry the same genetic variants. But otherwise, for those who do not carry, then you can assure those family members that their risk for glaucoma is similar to that of the general population. So in addition to screening of relatives, gene-based testing for early onset glaucoma can also be used to confirm diagnosis, especially for those diseases that have similar phenotype but different inheritance pattern. And test selection can either be screen panels, but now with the cost of whole genome sequencing really drastically coming down, you can even order, which is almost the same price as screening panels. So as I had alluded to, early onset glaucoma, we can now develop what we call the polygenic risk score to stratify risk management, to stratify risk. But however, it's important to remember here that unlike for early onset glaucoma, polygenic risk score is not intended to be a diagnostic test. It's only intended to be as a risk stratification tool. And importantly, primary open-angle glaucoma is actually quite an optimal disease for the clinical utility of the polygenic risk score because it's highly heritable, it has no strong environmental lifestyle risk factors, it has a prolonged asymptomatic disease phase with irreversible vision loss, and studies have also shown that early diagnosis and treatment can actually lead to prevention of vision loss. And I think what is really exciting is that we now actually have commercially genetic testing to compute PRS in adult glaucoma that is commercially available. This has been around for a few months now. So I'm not sure if you're aware of this, but this is a company called Sionix Bio, which was founded by ophthalmologists and researchers in Australia. So I'd like to say, yeah, I have absolutely no financial interest or commercial interest in this, but I think as healthcare professionals, as clinicians, it's important for us to know what is there so that I'm sure we all have patients who ask us, are there genetic tests? So now we actually do have something for adult onset glaucoma. So this is a company that provides a service for generating a polygenic risk score, which is called the SITE score. And currently, it is available to healthcare professionals only in Australia and New Zealand. And so the population for which it can be requested are those unaffected individuals with or without family history of glaucoma, glaucoma suspects or ocular hypertensions, as well as confirmed cases of glaucoma. So what are the clinical uses? It can be used to predict the risk of development or the age of onset of glaucoma. And for perhaps ocular hypertension, we know from the AIOS study that treatment can result in reducing the risk of development of POAG. So perhaps for those ocular hypertensives with a high genetic risk, they can be, treatment can be initiated early, as well as perhaps it can also be used for confirmed cases of glaucoma when you want to enhance treatment depending on the genetic risk. So this is my last slide really is, I mean, polygenic risk score is not something new. It's been there, it's been around for heart diseases, some cancers as well as for diabetes. So I think it is something that, and now it's available for glaucoma as well. I think it is something that clinicians, I mean, we'll have patients asking us about this. So in addition to understanding the benefits, also it's important to know what are the potential risks and gaps. So these are some of the benefits of polygenic risk score, but there are also some risks which can arise from incorrect information as well as correct information. So what I mean by incorrect information is that as with any other test, a genetic risk score can also suffer from imprecise risk estimates and false positive. So what is important is these tests should not be used as standalone tools, because perhaps if you use it as a standalone tool and a patient with false positive tests, it can lead to inappropriate clinical actions. Therefore, they should always be used in conjunction with clinical examination and evaluation. Now, risks arising for correct information, this is mainly related to communication of results, because as I had alluded to, it's not unlike the test for single gene diseases, it is not a diagnostic test, it's a risk stratification tool. Now, societal risk really results from issues related to insurance or employment. And it's also important to understand that currently most of the polygenic risk score are applicable to patients of European ancestry. That's why, so currently it is being developed and evaluated in persons of other ancestries as well. So in summary, there's been significant progress in understanding the genetic basis of glaucoma. For early onset glaucoma, there are availability of gene panels to confirm diagnosis and screen relatives. And for adult onset glaucoma, we now have commercially available polygenic risk, of course, currently applicable only to persons of European ancestry. So what do we hope to see in the future? What are we likely to see? Is personalized risk management assessment, not only for primary prevention, but also to guide management decisions and monitoring. And perhaps we may be moving, well, not too much in the near future, but I guess in the future to move towards what is happening with certain cancers is pharmacogenetics, when prescribing glaucoma therapeutics in the future. Thank you very much.
Thank you, Dr. Monisha. So if we take questions from the audience first, if anybody has any questions, please come to the mic and you can ask your questions. And a small remark to all the presenters, please, it's a request from the scientific office that whenever you present your talk, your second slide has to mention the financial disclosure. I couldn't see any financial disclosure mentioned for any of the speakers. This is against the guidelines given by the AIOS office. So request you all to please display the financial disclosure in your future talks wherever. Any questions from the audience?
Dr. Shalini, You know, we all struggle with the ocular surface in our patients, and I'd just like to ask you whether you have any recommendations, you know. What do you do when you have a patient of glaucoma with you and you're starting medication, you know? Is there something that you actually do so that, you know, maybe you will reduce, you know, the dry eyes or the other symptoms that the patient is likely to get?
Yes, sir, I definitely agree that we all struggle. I think before starting the treatment, what we should do is we should actually evaluate the ocular surface there and then. And if there is ocular surface problem, we should treat that immediately, there and then, so that whenever we are starting on anti-glaucoma medication, the patient may not, the problem may not worsen. Another important thing is that if we can use preservative-free glaucoma drops, that is always more helpful. And treating the ocular surface should be more focused, like suppose patient is having aqueous deficient dry eye, so we should target that only, rather than giving a cocktail of prescriptions, so that the effect of anti-glaucoma medication should also be there and patient is not burdened with too many drops. Suppose there is a lipid problem, then we should treat the meibomian gland dysfunction rather than targeting some other issues. So if we can categorize the patient on the regarding the ocular surface disease, regarding the severity, before starting anti-glaucoma medication, and accordingly deal our patient, then I think our patients will be better off.
Okay, thank you. So you are suggesting that we become a little, you know, specialists in cornea and spend some time
Definitely.
with the patient before starting. All right.
Yeah, thank you.
So thank you very much.
Excuse me, just one more. Do you regularly give the lubricating drops with your anti-glaucoma medications?
Yes, sir, most of the time it is required because most of the patients are elderly and they are having some or the other ocular surface problem. So adding one lubricant helps these patients very well and also helps in adjusting with the glaucoma drops, because most of the drops, even if they are preservative free, the primary drug itself is responsible for ocular surface problems. So I think it is a good idea to add one lubricant eye drops with them.
And if you don't mind, I have one question too.
Yeah, sure.
In case of a lipid problem where there is blepharitis and the meibomian glands are plugged, do you have hesitation in starting a prostaglandin drug?
Prostaglandin, because they also increase inflammation and already the eye is already inflamed, the patient don't tolerate it very well. So I think if we can treat the meibomian gland dysfunction, before that we can give some other anti-glaucoma medication, and once the patient has responded to treatment, then we can add prostaglandin.
Switch.
That is, that is more helpful.
Thank you.
Thank you.
So I just want to go on to the optic disc and retinal nerve fiber layer, and that's Dr. Medha Prabhudesai and Dr. Shushmita and Dr. Asrani. You know, it just so happened that we got technology to see the optic disc with the fundus camera before we got the technology to see the retinal nerve fiber layer. And I'd just like your opinion. You know, there was a time when, of course, we had to treat glaucoma patients because only with the optic disc and the perimetry, which came after. But if I took the optic disc analysis, if I took the optic disc away from your glaucoma examination, you know, are you going to be able to survive and treat your glaucoma patients just on the basis of, let's say, the retinal nerve fiber layer, ganglion cell, and perhaps even with the automated perimetry?
No, actually, glaucoma, always I say that it is like a puzzle. So you have to fit all the pieces together. Then only you can say that it has glaucoma. Without optic disc examination and other parameters which are required for optic disc examination, you won't be able to survive, because only perimetry will not suffice. So you have to do maybe now.
Yeah, so I was suggesting that if you had retinal nerve fiber layer and ganglion cell and perimetry, but you didn't have the optic disc to examine, would that be enough, or you would still want the optic
no,
disc?
I would like to have still the optic disc to correlate everything with the optic disc.
All right.
So because see, if suppose, so I'm just giving you an hypothetical this thing. If a patient has a branch retinal vein occlusion, it will show as a defect in perimetry also, and in OCT also it will show as thinning, but it may not be glaucoma. So without glaucoma and without fundus examination, it's not possible.
Okay.
We do get a lot of reports from our patients' relatives.
And you also, that you do want the optic disc.
Yes, because in the absence of cupping, we cannot define it as glaucoma, as you said correctly. So it has to be a loss of tissue within the optic nerve. Of course, there are situations where we get really, as Vinay pointed out, we can't see the optic disc. Like, for example, in severe diabetic burnt out proliferative retinopathy, the disc is covered with a fibrous tissue. Or in patients with the very severe myopia, the disc is so tilted and so contorted that you can't make out anything from the disc. In those cases, well, then you're left to, there is no choice.
What happens is we do get a lot of reports from the patients and the relatives. They just send the fields and the OCT. So this is a take-home message that without the disc evaluation, we are never going to start any treatment. So for the PGs, this is very, very important for attending.
So I just want to move into the future with Shushmita and Sanjay also, that, you know, with all this technology coming in, you know, if I took the patient away from your clinic and just gave you the technology, you know, so you have everything, you have the optic disc photograph and you have the retinal nerve fiber layer. And of course, let's say that it's your clinic, so you know that the workup has been done properly, you know. Would you still insist on seeing the patient because you want to talk to him, or because it's going to help you actually, you know, make a better decision?
I think it would depend on the stage of the disease. I mean, for instance, taking a leaf out of the virtual optoms clinic, which are there, if there's a disc suspect and somebody sends me normal fields, a normal disc on a picture and a normal OCT, it's possible that I tell somebody, no, it's okay, and tell them on the WhatsApp it looks
not
fine
normal.
to me.
I'm talking of completely abnormal, difficult cases.
Yeah,
you
so
know.
if there's an advanced glaucoma or something, I would of course say that I would like to see the patient.
Okay.
Given a choice, always yes, but it's not mandatory in all cases. Maybe that's what I'd think.
Sanjay, how are things in America for you?
Well, if you are only looking at the results, you are not a doctor, you're a technician. You have to look at the patient, talk to the patient, address that person's anxieties, fears of going blind from glaucoma. Is there that sometimes you realize that the patient is on 3 antihypertensive medicines or is having kidney failure, and then you realize that what you're seeing in the retina is actually not glaucoma even. All those nerve fiber layer defects are coming from hypertension. So then, of course, there is, as Sushmita said, of course we want to see the patient, but if there is no choice and you had to say out of these 100, which ones you'll send home, then of course you'll only choose the normals.
Okay, yeah, go ahead. But take the mic, Surinder. Yeah.
Maybe if you know the patient is coming regularly, and for maybe 1 or 2 follow-ups, you can do virtual clinics like thing, but not for diagnosing and for managing the patient.
So that's what we do. We do what is called technician-only visits, where patients come in, get their pressure checked. We give them guardrails, like if the pressure is above this and below this, then the technician has the discretion to send the patient home.
I was just wondering what Venkatesh has to say, because his sensitivity and specificity is with AI is 90% already, which is better than actually, you know, most residents involved in like teleconsultation or something. So I think there's a very strong point that a lot of these patients can be helped remotely, but at the end of the day, I think we have to see the patient, because not only the diagnosis, you have to speak to the patient and explain, you know, what is there now and what is going to happen in future. So I think talking to the patient is kind of indispensable, but other things they do help.
Yes, yes, thank you. Go ahead.
Just to add a point, I think in COVID we learned a lot, including how to do in COVID times. Now, when we were not able to see patients, we realized how difficult it is for somebody to travel to reach a physician. Maybe if we can reduce the visits, let's say you want to see them every 6 months, can it be every year now? They don't want to see you every 3 months or 6 months. They are fed up. Like the HFA image you saw, they don't want to do that. So that's why I think people run these stable glaucoma clinics. If you feel the disease is stable for n number of visits, and then you can make it like a yearly or once in 2 years, and then in between you can rely on the technician or the investigations done. And that's where we found you can even Uberize an eye care. can we take home some of these equipments, which are all available now, an eye care, a VR perimetry, a portable OCT, and then from home, you do telemedicine and say, bye, I'll see you next year. I mean, you can even touch that emotional part at the same time, reduce their travel, which is a significant carbon footprint also.
I mean, you know, the point is that, from what some of my friends tell me in Europe, that the medical health system is really struggling to serve the people who are 80 years and above, to the point that, they sense that they may not be getting appropriate treatment now, actually. And if it's all about finances, so maybe what everyone's talking is something that's going to happen perhaps in India also. Go ahead, Alan.
Yeah, I think this is a fantastic discussion, and it's really important. The number of individuals over 65 is going to increase tremendously, unless diabetes kills them all, in the next 20 years. The number of physicians, ophthalmologists, who are comprehensive ophthalmologists, not retina specialists or retired surgeons, whatever, but people could take care of them, will be increasing, but not at the same level, according to the predictions from the RAND Corporation and other corporations. We have a real problem. One of the problems I'll bring up this afternoon is that patients don't take their medicines because we don't talk to them. We don't tell them what they need to do. Even counselors don't do a very good job. And we need AI to help us with that, Venkatesh. That's another issue we have to deal with. But I think that as Sanjay had a slide.
Can you come a little closer to the mic?
Oh, I'm sorry. I apologize. As Sanjay had the slide of the person on the rack, just going to the doctor's office is getting the rack. Nobody wants to see it. Nobody wants to wait in a clinic for hours, exposed to other people with viruses. Nobody wants to be in the clinic because they'd rather be out there. And everybody who goes has another person accompanying them, so you're taking two people out of the workforce or doing something else. So we need to basically streamline and think about processes where we don't bring people back. There's eye care tonometry. There's going to be a paper that'll be published very shortly, we hope, that'll look at, if you get somebody's pressure every 3 months or 6 months, what have they done in the middle? We don't know what their pressure really is. We know it's sporadic pressures. And visual fields should be done in clusters. So we're doing these visual fields, wasting room. We can do virtual reality visual fields, which are very good. So patients can take them home, do all these visual fields once a week. And you know what is short-term and long-term fluctuations. We've seen lots of visual fields. So I think we have to, the world is our oyster right now. There's so many things we can do. So let's do them. Let's think about how to do it.
Thank you. So we're really just out of time, but Parul, I just wanted to ask you, so if you had a patient that came to you, and you're suspecting that the patient has glaucoma, you think the patient has glaucoma, what would be your strategy for the perimetry that you did for the patient, actually?
So as a standard protocol that we are using at our center,
Yes.
that's 24-2 CETA fast. We're not using CETA standard anymore for all our patients. So if the patient is doing pretty well on this CETA fast protocol, would stick to it. It's only in certain cases where I'm also doing an OCT and finding a change in the macular GCC that I've recently started using the 24-2C. But otherwise, I'm adhering to the standard institutional practice of using the CETA fast 24-2 in most of my patients.
So, the reason I asked this question is to ask you whether you would use the 10-2 for every single glaucoma patient that came to you, actually.
No, not really. Unless I'm suspecting a normal tension glaucoma, or if I have like a ocular hypertensive who is a high-risk patient, only then, in addition to rest everything else appearing normal, am I using a 10-2 as an addendum to 24-2. But not, solely a 10-2 right in the beginning for everybody. No,
So
not really.
The reason I'm suggesting is that, a lot of the patients that we think who have early glaucoma actually have, visual field and ganglion cell loss just in the central area, actually. And so that's why maybe it'll help to diagnose these patients even better also, because of how nicely you described the number of points that you have in the central area with the 10-2, I'd just like to, take Dr. Surinder's opinion and, who are the experts in automated perimetry? Dr. Venkatesh, Sushmita.
So we were very excited with the 24-2C when it came, because you had 10 extra points with 2 degrees and all that. But since it's a faster strategy, we realized there were lots of false positives as well. So our strategy now has become a 24-2 CETA standard when they come in first, get them out of their learning curve, and once they understand what's to be done, then I follow them up on 24-2C. And I think, and if I find a spot in the 24-2C, I switch to a 10-2 after that.
Perhaps why I'm saying about the 10-2 is because we're used to doing the ganglion cell and the retinal nerve fiber in every single patient that comes to us actually. And so we've really been surprised at the changes that we see in the ganglion cell layer loss actually. And that only correlates really
with the 10-2.
With the 10-2,
Correct.
All right.
I just wanted to make one point about the visual fields for the audience, and that is that these machines will provide you a GPA regardless of the strategy used. So sometimes you are seeing the first 2 baselines, a CETA standard, then the follow-up is CETA fast, but the machine will provide you a GPA. You have to realize that it is a different strategy when you look at the printout of this.
The last comment from Alan, we're out of time.
Yeah, we are finishing a long-term study looking at progressing visual fields. These are people who've known progression, and we're following them. And this is with Chris Johnson, University of Iowa Visual Field Center, with University of Iowa Visual Field Center. We have Joel Schumann and OCT, so it's a very sophisticated study. Turns out that the C24-2 faster with this more spots really is the key to looking at progression in the group of people from -2 MD to -12 MD, which not surprising, but it was very nice to really find that out. So I'm not going to say much more.
Thank you very much, my colleagues and all the faculty and the audience also.
I invite all the speakers and we just have a group photograph. There's a half-an-hour gap, I guess, for the next session. So it's a tea break. The next session, WJ session, will start at 11 o'clock.
No, I'm not in.